My name is Mimi Tan, and I'm an assistant professor in the section of gastroenterology and hepatology at Baylor College of Medicine in Houston, Texas. I would like to thank Gastrointestinal Endoscopy for the opportunity to present our paper titled Validation of a Pre-Endoscopy Risk Score for Predicting the Presence of Gastric Intestinal Metaplasia in a U.S. Population. Who should we screen for gastric intestinal metaplasia? Gastric cancer is thought to develop via a progression from gastric atrophy and gastric intestinal metaplasia, or GIM, mostly in the setting of H. pylori infection. Thus, GIM is considered an important precursor of gastric cancer and a promising target for screening and endoscopic surveillance to facilitate detection and early treatment of early gastric cancers. We previously described several demographic and clinical risk factors for GIM. Based on these risk factors, we developed pre-endoscopy risk prediction models for the presence of GIM in a U.S. veteran population within Houston, Texas. We compared three models: a model with H. pylori alone, a baseline model with sex, age, race, ethnicity, and smoking status, and a third model which combined the baseline model and H. pylori. The baseline model plus H. pylori model shown in blue, which included sex, age, race, smoking, and H. pylori, had the best performance in detecting GIM with an area under the ROC of 0.73. The baseline model alone, shown in green, and the H. pylori models, shown in red, underperformed the model which combined these two models. The aim of our current study was to externally validate a predictive model for endoscopic GIM previously developed in a veteran population in a second U.S. population. Why was the study conducted? The models were developed among patients recruited from primary care and endoscopy clinics at the Michael E. DeBakey VA Medical Center in Houston, Texas. 423 GIM cases and 1796 controls underwent EGD with gastric mapping biopsies between February 2008 and August 2013. We validated these models in a second cohort of patients from 6 CHI St. Luke's hospitals in Houston, Texas. These 215 GIM cases and 2469 controls underwent gastric biopsy for either symptomatic indication or endoscopic findings from January to December 2017 and were identified using CPT codes. Cases were defined as having GIM on any gastric biopsy, and extensive GIM was defined as involving both antrum and corpus. We applied the three models developed in the VA cohort to the second CHI St. Luke's validation cohort and reported model performance as area under the ROC. What were the results? In the development cohort, GIM cases were more likely to be male, older, non-white race ethnicity, smokers, and have H. pylori infection. Similarly, in the validation cohort, GIM cases were older with higher proportions of non-white race ethnicity, smokers, and H. pylori infection compared to controls. Here, we show the model performance for predicting GIM in the VA cohort used to develop the model and the validation cohort at CHI St. Luke's. In the CHI St. Luke's validation cohort, the baseline plus H. pylori model, shown in green, performed better with an area under the ROC of 0.62 than the model containing H. pylori alone, shown in red, and the baseline model, shown in blue. As expected, the model performance did drop in the validation cohorts compared to the development cohorts. Here, we show the model performance of predicting extensive GIM in the VA cohort used to develop the model alongside the CHI St. Luke's validation cohort. The baseline plus H. pylori risk model, shown in green, better predicted extensive GIM with an area under the ROC of 0.71 compared to the baseline model and the H. pylori model. The area under the ROCs, again, were uniformly lower among the external validation CHI cohort compared to the VA development cohort. In order to optimize model performance and enhance transportability, we pooled the VA and the CHI St. Luke's cohorts and developed new risk estimates. The new risk models use the pooled cohorts, shown on the right, has better predictive performance for GIM and extensive GIM than the CHI St. Luke's validation cohort shown on the left. Why does this matter? We externally validated a pre-endoscopy risk model for predicting GIM developed in a VA population and a second cohort of patients from St. Luke's hospitals. The model with sex, age, race, ethnicity, smoking, and H. pylori performed better than the H. pylori alone at predicting GIM. Risk stratification tools can identify patients with the highest benefit from endoscopic screening for GIM. Recent studies have shown that referring patients for endoscopy based on H. pylori test alone is not a cost-effective screening strategy for gastric cancer. Our study showed that combining H. pylori with these measurable, objective demographic risk factors can better predict who will have GIM and the most benefit from endoscopic screening. Future studies should further validate our findings in other U.S. populations. Thank you for this opportunity to present our work.